Yes, I think this year is a very exciting year for treatment of muscle-invasive bladder cancer in the perioperative setting, because in the past we've been using the standard of care cisplatin-based chemotherapy preoperatively before cystectomy, and then we've seen patients with good response. However, there is a significant proportion of patients that do recur after such a very intensive therapy. However, with the new incorporation of immunotherapy, for example, this time with a Niagara regime, giving anti-PD-L1 antibody durvalumab in the preoperative neoadjuvant as well as the adjuvant setting together with a cisplatin-based chemotherapy, in fact, actually help patients to improve the progression-free survival as well as a very meaningful overall survival benefit. I think because with the use of immunotherapy before the operation, when the tumor cells is in situ, before we take it off by cystectomy, we kind of educate the body's immune system to a better level in order to fight against the cancer cells before the operation, and the post-operative adjuvant durvalumab also helps to consolidate this immune response. So I think this actually translates into a very good clinical response of our patients. Health-related quality of life data have been a very important factor for us, and we've been looking forward to seeing the result, and it's now finally available, because we are talking about a curative perioperative setting. So whether additional of a drug would cause a detrimental, harmful effect to the quality of life is actually very important. And we are happy to see that with a combination of chemotherapy plus immunotherapy, durvalumab, we didn't see any detrimental health-related quality of life impact on the patient. In a way, improving the patient's survival, surgical outcome without the cost of the patient's impaired quality of life. And I think this is very reassuring for us in the community of oncology. Nowadays, with the advances of the systemic therapy options in patients with muscle-invasive bladder cancer, in our center, we adopted a multidisciplinary approach where we medical oncologists are working very closely together with surgeons, urologists, as well as radiation oncologists. So we will discuss all the patients before the operation, and if the patient needs any systemic therapy, including chemotherapy or immunotherapy, we'll be the one who's mainly delivering it, because we will be monitoring the patients closely and manage any potential side effects. And in fact, when we're working as a team, we found that all of these newer systemic therapy options can be very safely delivered to patients, and the surgical outcomes indeed can improve also. This year, we see a really exciting bunch of trials coming up. And I think there are two main trends. One is that we are very reassuring that immunotherapy is going to be the game changer in management of bladder cancer patients, all the way from the refractory second and third line setting to the front line setting, and even in the perioperative neoadjuvant setting. And the second one is the management of bladder cancer is getting to be more and more personalized with the new readout of trials from the antibody drug conjugates. So we see different targets, and they all showing promising results. And I think in the future, the main challenge is really how do we select patients. If patients are eligible for multiple potential regimes, how do we best select and sequence these patients? These questions remain to be answered.